The incoming president of the Neurodiab and also the professor, most of all from the University of Thessaloniki, Greece, on the topic disease-modifying agents of diabetic neuropathy, where we are. Please.
Dear Chair, colleagues and friends, good morning. I am honored for the kind invitation from the President of Neurodiab, Professor Vincenzo Spallone, and the Executive Committee to participate in the present session. From a clinical or treatment perspective, the presentation will delve into the most recent data about the disease-modifying treatment in diabetic neuropathy. The field holds great potential for breakthroughs. As a clinician interested in diabetic autonomic neuropathy, I'm excited to share insights on autonomic dysfunction. The management of diabetic neuropathy includes three cornerstones: the causal treatment with lifestyle modification, intensive diabetes therapy aimed to near normal glycemia, and multifactorial cardiovascular risk intervention. The pathogenesis-oriented pharmacotherapy, and the symptomatic pain relief. We discuss in the present, during the presentation, the second statement. A disease-modifying treatment is a treatment that delays, slows, or reverses the progression of a disease by targeting its underlying cause. Improving glycemic control has been shown to be highly effective in reducing microvascular complications in type 1 and diabetes, but to a lesser extent in type 2 diabetes. Diabetic neuropathy affects up to 50% of patients with diabetes mellitus with duration for more than 10 years. Toronto panel on diabetic neuropathy concluded that the prevalence of confirmed cardiovascular autonomic neuropathy in non-selected people with type 1 and type 2 diabetes mellitus is approximately 20%, but can be as high as 65% with increasing age and diabetes duration. Even from the landmark studies results in type 1 and type 2 diabetes, the current strategy, targeted glycemic control, could not entirely prevent the incidence of diabetic peripheral neuropathy and autonomic neuropathy, as shown in the studies DCCT, Professor Tesfaye's studies, and many other studies. The etiology seems to be multifactorial. Managing diabetic neuropathy is not just challenging, but urgent. Other causes and factors may play a role in developing complications, so additional treatments have been investigated with many molecules in managing diabetic neuropathy. The pathogenetic mechanisms in diabetic neuropathy have been investigated in many preclinical and clinical studies, and now many drugs target these mechanisms. When proteins and lipids are exposed to high blood glucose levels, they form heterogeneous molecules with a high level of reactivity known as glycation products. This is a major pathogenetic mechanism with unknown products until now and the main therapeutic target. The formation of phages may be the most important mechanism. The age pathway has complex mechanisms, and they can lead to factors that damage nerve cells, such as inflammation and oxidative stress. The other central pathogenetic mechanism is the hyperactivity of the polyol pathway. Blood glucose enters the cell freely without the need for insulin, not only in neurons, but according to recent studies also in endothelial cells. Thus, these cells are exposed to blood hyperglycemia directly. Diabetic peripheral neuropathy is usually easily detected by a simple clinical examination. Shoes and socks should be removed, and the feet should be examined annually, and more often if neuropathy is present. The most common presenting abnormality is a reduction or absence of vibration cells sensing the tissue. The two divisions of the autonomic nervous system, the parasympathetic and sympathetic, work in balanced opposition to control heart rate, the cardiac contraction, the force of the cardiac contraction, the dilatation and constriction of blood vessels, the contraction and relaxation of smooth muscles in the digestive and urogenital systems, blood secretions, and papillary size. Diabetes can cause dysfunction of any or every part of the autonomic nervous system, leading to a wide range of disorders. Cardiovascular autonomic neuropathy is one of the most overlooked, underdiagnosed, and untreated of all serious complications of diabetes. Cardiovascular autonomic neuropathy is a significant cause of morbidity and mortality associated with a high risk of cardiac arrhythmias and sudden death, possibly related to silent myocardial ischemia, malignant arrhythmias, and QT prolongation. Toronto panel defined cardiovascular autonomic neuropathy as the presence of two or more abnormal cardiovascular reflex tests, although heart rate variability time and frequency domain indices are widely used in many studies. The ability of heart rate to change has been recognized as a sign of healthy cardiac function. In the picture, you can see an abnormal deep breathing test with no change in heart rate during inhale and exhale. And then normal deep breathing test, there is an increase in heart rate during inhale and a decrease during exhale. This is another statistical analysis of deep breathing test showing the distribution of heart rates. In the normal test, you can see a wide distribution of heart rates, but in the abnormal test, you can see that heart rate is fixed, locked around 100 beats per minute, without the ability to change. Below, you can see a normal postural test and an abnormal postural test, and a normal Valsalva test and an abnormal Valsalva test. In all abnormal tests, the heart rate variability is reduced as shown. My first step in the research of diabetic neuropathy was the use of ACE inhibitors in the management of diabetic autonomic neuropathy. It was the time of using the ACE inhibitors in the cardiovascular disease with beneficial efficacy in these disorders. Our journey with ACE inhibitors began 3 decades ago. In our initial study, we uncovered a significant improvement in heart rate variability indices following 6 months of ACE inhibition. The lack of change in cardiovascular reflex tests and vibration perception threshold in that study was a finding that piqued our interest and set the stage for further exploration. In addition, the study of Professor Malik, published 1 year later, and evaluated the efficacy of Tandolapril in patients with diabetic neuropathy and found an improvement in electrophysiological tests. In a more recent study, we evaluated the efficacy of Quinapril in diabetic neuropathy. We found an improvement in indices of deep breathing test in the active group and deterioration in the placebo group. But again, no improvement in peripheral neuropathy. We continued exploring the relationship between cardiovascular autonomic neuropathy and left ventricular function using radionuclide ventriculography, the most reliable scintigraphy technique to assess cardiac function. Cardiovascular autonomic neuropathy may be associated with abnormalities in left ventricular systolic and particularly diastolic function in diabetic patients without cardiac disease. Left ventricular diastolic dysfunction may progress to heart failure, mainly with preserved left ventricular systolic function. This finding underscores the importance of early detection and intervention in managing diabetic patients. In the slide you can see, in patients with autonomic neuropathy, the ejection fraction was higher than in patients without autonomic neuropathy. And the diastolic indices, the atrial contribution to ventricular filling, and the first third filling fraction during diastole were impaired. Remember these indices for the next slide. Where we found an improvement with the use of ACE inhibitors and angiotensin receptor blockers. In this slide, in the deep breathing test, using quinapril, losartan, and their combination after 1 year. And moreover, in indices of diastolic dysfunction. In the slide, in the first third filling fraction. ACE inhibitors and ARBs reduce central sympathetic neural discharge, as well as reduce norepinephrine spillover rates and improve tissue clearance at peripheral nerve terminals. The beneficial cardiovascular autonomic effects of ACE inhibitor and ARBs appear magnified in conditions with exaggerated sympathetic overactivity or baroreflex dysfunction. They have also action on vasodilator effects and action on ages. The other compound is the alpha-lipoic acid that acts as a cofactor of mitochondrial enzymes and is able to scavenge free radicals, regenerate endogenous antioxidants, and repair oxidative damage. Several randomized, double-blind, placebo-controlled clinical trials have explored the efficacy of lipoic acid for diabetic peripheral neuropathy. The vast majority of the several studies in which lipoic acid was tested demonstrates an analgesic effect of lipoic acid in diabetic painful neuropathy. Only a few trials suggest that lipoic acid may improve neurophysiological parameters in diabetic neuropathy. In studies where lipoic acid used for the treatment of autonomic neuropathy and in combination with other compounds has been shown a favorable effect. Aldose reductase is the enzyme that catalyzes one of the steps in polyol pathway, which is responsible for formation of fructose from glucose. However, with the exception of epalestat, marketed in Japan and India, all other aldose reductase inhibitors have been withdrawn from the market or never introduced for toxicity or lack of efficacy in the treatment of diabetic peripheral neuropathy. A meta-analysis of 10 studies showed that aldose reductase inhibitors could ameliorate cardiac autonomic neuropathy, especially mild, although asymptomatic, with a good safety profile. The new research topic is the role of vitamin B12 in diabetic neuropathy. In this issue, there are many unanswered questions. Is neuropathy caused by diabetes different from B12? When does B12 deficiency cause neuropathy? And is it reversible? Would a combination of good glycemic control and normalized levels of B12 to reverse diabetic neuropathy? Vitamin B12 has analgesic properties in pernicious anemia. Is it true in diabetic neuropathy due to B12 deficiency? Vitamin B12 deficiency does not represent all the diabetic neuropathy risk. Pernicious anemia was described 80 years before. At that time, it was a deadly disorder. The main presentations of pernicious anemia are hematological and neurological consequences of vitamin B12 deficiency, and both require several years for their development. Clinically, B12 peripheral neuropathy is indistinguishable from that of diabetes. It's important to consider that peripheral neuropathy caused by B12 deficiency may also remain subclinical and interact with that of diabetes, highlighting the need for a more careful approach in a diagnosis and treatment. B12 deficiency due to metformin use and other causes may contribute to increasing the substantial burden not only of peripheral but also of autonomic neuropathy in diabetic patients. Neuropathy is a common complication of diabetes, and its attribution to metformin-induced low vitamin B12 status can never be certain. So the aim of our study was to investigate the efficacy and safety of the administration for 12 months of an oral dispersible tablet containing vitamin B12, 1 milligram per day in patients with diabetic neuropathy. And the results, the hemoglobin A1C was below 7 in both groups and stable during the follow-up. In the active group, we found an improved level of vitamin B12, an improved in symptoms, in electrophysiological tests, in vibration perception threshold, in pain score, and pseudoscan indices. We did not find an improvement, in cardiovascular reflex tests also, but we found a slight improvement, but not statistically significant. But cardiovascular reflex tests remain stable. In the placebo group, there was a deterioration in symptoms, in electrophysiological tests, in cardiovascular autonomic neuropathy test, and in pain. The clinical message is that the diabetic peripheral neuropathy and pain improved in the active group, but after 1 year, the diabetic neuropathy deteriorated in the placebo group, despite the fact that the hemoglobin A1C value was below 7. We also published a review about the mechanism. The recognition that B12 exerts intrinsic antioxidative activity indicates a new role of B12 in cellular metabolism beyond its classical, well-known cofactor function. Since several studies point to an involvement of oxidative stress in the development of diabetic peripheral neuropathy, the antioxidative potential of B12 suggests that B12 administration may be justified not only for the therapy of overt diabetic peripheral neuropathy, but also in early stages of diabetic peripheral neuropathy, or even for the prevention of diabetic peripheral neuropathy when cellular oxidative stress is present, but symptoms are mostly absent. The absence of a clinical improvement after B12 administration in some studies does not exclude a possible favorable effect of B12, because oxidative stress is probably only one of the multiple mechanisms leading to diabetic peripheral neuropathy. Another serious complication is diabetic gastroparesis. And I would like to show how technology could help us in the treatment. A woman was admitted to our outpatient clinic for evaluation 1 year before. She had severe and frequent episodes of hypoglycemia and hyperglycemia with frequent admissions to emergency room. She had also severe diabetic neuropathy and orthostatic hypotension, drop of systolic blood pressure more than 50 millimeters with episodes of syncope. She could not even stand up. Minimal symptoms were reported from the gastrointestinal system. Every insulin treatment received with 2, 3, 4 injections, even 1 hour, 2 hours after meals, failed. She started the 780 system, insulin pump, the only available system in Greece, and sensor, after 30 months of her admission, and these are the 3 months recordings. 9 months recordings in total. Hypoglycemia episodes vanished. Glycemic control improved. Diabetic neuropathy did not improve, but gastroparesis improved. The patient's life was saved from the severe episodes of hypoglycemia, and of course glycemic control improved. We observed a remarkable improvement in scintigraphy gastric emptying tests after 6 months of follow-up. You can see in the first test, after 4 hours from the meal, around 70% of the meal was in the stomach. The clinical message is that good glycemic control is significant in gastroparesis and should be achieved. From the newer drugs on diabetes, the SGLT2 may improve autonomic function, and the use of GLP-1 agonist is under investigation. There are many other molecules investigated in the treatment of diabetic neuropathy, but we have not now time to discuss all of them, and of course they have little efficacy till now. At present, pharmacological treatments for neuropathy are primary palliative. While they provide temporary relief from pain, they do not address the underlying mechanisms. This underscores the urgent need for pharmacological interventions that can simultaneously target pain and the underlying mechanism of neuropathy. Such drugs could provide more comprehensive and effective relief, addressing both the symptoms and the root causes of the condition. Most existing clinical studies investigated one part of neuropathy, either peripheral, mainly painful, but the majority is painless, or autonomic. Data about vitamin B12 measurements have not been reported in most studies. The duration of the studies investigating neuropathy should be at least 1 year. And in conclusion, despite some promising results in the marketing of some drugs in many countries with indications for diabetic neuropathy, disease-modifying treatments still need to achieve approval from the main regulatory agencies. Diabetic neuropathy is an early complication in patients with diabetes mellitus. Strict glycemic control is now the only recommended treatment. Early identification and management are necessary to prevent the deterioration of diabetic neuropathy. ACE inhibitors could be an additional treatment. Annual measurement of vitamin B12 recommended. A combination treatment acting on 2 or 3 etiopathogenetic mechanisms could help manage diabetic neuropathy in the future, in addition, of course, to good glycemic control. Thank you for your attention.
Thank you very much, Triantafyllos, and we kindly invite the virtual attendees to send in questions also. And this presentation is now open for questions from the floor. Please. Andrew, please.
Andrew Bolton, Manchester, UK. As you pointed out, Reyes and I reported on the ACE inhibitors in the Lancet in 1998, and yet B12 is another interesting one. Most patients with diabetes are actually taking an ACE inhibitor or an A2 receptor blocker, but they're not taking B12. So would you suggest that any people with early signs of neuropathy, irrespective of their basal levels of B12, should be on some form of B12 supplementation, especially those on metformin, for example?
The level of B12 below 230/50, according to what technique you measure, is you can use it as an index, as you say, for the vitamin B12
but
replacement.
Do you think even people with low measures in the normal range should be on B12 from your data?
From?
With relatively normal levels of B12.
The normal levels are above 400. Above 400 to 900.
I know what they are, but should we be using B12 more in people with relatively normal B12 levels? Those with early neuropathy, that's the question.
The normal level is above 400 to 900.
I know. What I'm asking is, should many people with normal range B12s be put on B12 supplementation if they have neuropathy and are on metformin?
In the normal level? Yeah. We did not test it right now.
So I think we have time for one more question, and then we'll end this. So if no further questions from the floor, I might have a little intriguing question. What do you see in the pipeline coming up in terms of pharmacological agents to modify or even prevent diabetic neuropathy?
I can hear you well.
So what do you visualize in the pipeline from new upcoming modifying agents?
Some of them may be promising, but they need more studies, maybe randomized control studies to find the results, the improvement.
Yeah. Well, thank you very much, Triantafyllos, and